So we talked before the pod. I work in the telehealth space. We do remote patient monitoring, chronic care management, and we kind of help patients with devices and management that remotely. And we have nurses that talk to patients via telehealth. Obviously, that exploded, during COVID because it was just hard to see patients. Talk about your experience with it, and then what are your thoughts about it now? Now that we're getting, somewhat back to normal.
Yeah, I definitely had to do that during COVID. I was working in hospice, and the majority of patients are treated in their homes, the majority of hospice patients. And so the first year or two of COVID, when we just really didn't know what was going on, it was precarious to go into patients' homes. They didn't want us coming into their home, right? And exposing the rest of their family and their safe home environment. And so we had to do telehealth, and, it was necessary at that time. I personally am of the opinion that it is a very slippery slope. And it's dangerous because what they're doing in some cases is using like a remote nurse in hospitals where there's a TV mounted on the wall, and I'm sure you've seen it. And there's a nurse that's somewhere else at another location that can turn their camera on and communicate with you. Now, if they utilized that correctly and it was simply supplemental to nurse staffing, that would be fine. That would be helpful if we had them just come in to do maybe the discharge planning and education, or if a nurse needed a second RN to witness something, those situations. But unfortunately, what we're seeing is that they're saying, "Oh, well, we got you. We got you these remote nurses. So now we're going to increase your ratios, and you're going to have one or two more patients than you did before." Anything that they can ever use as an excuse to increase ratios and use less nurses, they will do every single time. And so it's almost being weaponized against nurses, and it's not good for patients in every setting.
No, that's a fair point. I think we see it also, like I was mentioning about my wife and how we employ nurses. It allows flexibility for nurses that want to get out of the bedside, right? And they can
Yeah.
do something
Oh, yeah, it's a
different.
great gig for a nurse that wants to not be beaten down every day. Yeah, it's a great gig.
Yeah, and not to say, instances where we've seen patients, get a little egregious with their verbiage and things like that. But to
Mhm.
your point, that's definitely a lot safer than having a patient in your face in the hospital. But so I think that helps, and we're definitely. But you're right. I think that's just the nature of just with administrator or owners and labor. I mean, you hear the similar stories around manufacturing, right? The robots taking manufacturing jobs, and
Yeah,
the advent of AI, artificial intelligence, right? There's rumors that they're
yeah.
trying to create that kind of AI nurse that can answer questions for for the
Terrifying.
patient remotely. And we already know from a technology standpoint, artificial intelligence can hallucinate, basically make up stuff. And
Yep.
so, I just don't trust AI to, help me through my illness, right? Sometimes
Right.
because it may get it wrong, or there's not a human being that can kind of feel or have empathy for your pain. So yeah, I think that's always going to be an ongoing challenge, and I think more organizations should start thinking about that as technology becomes more prevalent. And I think I read somewhere AI, they said they're trying to replace like something like 300,000 jobs over the next several
Mm,
years. So
yeah. Yeah. It's terrifying. I mean, it's one thing if you have a robot that's going to go fetch you a blanket or some ice chips. Okay. But do you want this robot to do invasive procedures on you, on your body, on your loved one? Do you want this robot to be interpreting your test results, your lab results, not knowing what a nurse that has done and seen this 20 years sees? you know they're just going to go by a protocol, right? Well, this and this equals this, but a nurse is going to go, well, there's also this other thing going on that could be a component.
I agree 100%. When you look at the space that we're in is remote care. And so basically we provide like devices, blood pressure monitoring, chronic care management services for patients at home. And that's enabling of that is telehealth services, right? And so obviously that became a big thing during the pandemic. And so now we're, kind of going back to normal where people still kind of see the doctor. But as a direct primary care, you kind of hinted at it, right? They can call you, text you, have
Mhm.
conversations. Kind of talk a little bit about like how are you using telehealth to build a better connection to your patients?
I think it's really that availability and flexibility and convenience that telehealth provides, especially since the COVID era. Patients want to stay home, and they don't necessarily want to come into the doctor's office. And so having the flexibility to say, let's just do check ins from home, it just helps with adherence because you can kind of see them more frequently with telehealth. And I think patients feel more cared for because you are checking in on them, or they have the ability to kind of report their issues in a convenient way for them.
Yeah, and I think convenience and then, the cadence, having consistent outreach and communication because, oh, doctor, I had questions about this medication real quick, all right? And so now the adherence is fast. And we've seen that a lot of times. Having a nurse or someone kind of reach out proactively, patients like, oh, yeah, by the way, yeah, this medication, I'm feeling some kind of way. A lot of people don't want to reveal stuff until you kind of go out your way to kind of
Mhm.
communicate it. And so,
That's a good
so
point.
so to your point, having that kind of cadence and people feel that that trust factor goes up, right? I was talking to practices doctors who practice all across the country. And we talked about like, how do you build trust with patients? One of the
Yeah.
things they told me is like, having being transparent about who you are and what your values are. And that helps, get the patients to open up. What are some other things you do to kind of ensure trust via telehealth or just in your practice so patients feel, more comfortable to kind of
Yeah.
to open up a little bit more so you can help them.
I think that's a really good point. I think that a good number of my patients do have some distrust in the medical system. And that's kind of why they've sought me out, because they've found me on social media and they've even been just following me for a while before they actually sign up for their membership, because they kind of want to see what I stand for, want to see what I advocate for. And I think that's kind of the big thing, is just to try to be an advocate for my patients. I think just being true to what I kind of preach on social media about really listening to patients, following through with it, actually sitting down with them. We don't go to the exam room right away. We come to my office, we sit down, we have a conversation, and I kind of ask them what they're looking for, what they're hoping for in a doctor, and kind of help guide their treatment plan in that way. Some patients want to be on medications, other patients want to try lifestyle first. And so I just try to see what their preferences are and help kind of guide their treatment plan that way. And I think that helps patients feel more comfortable just from the get go, just sitting down and chatting.
Hmm. Hmm. I love it. And that definitely, we always talk about the triple access, right? Lowering costs, improving quality, increasing access. Direct primary care is helping in all those kind of facets, right? Definitely, especially quality, because quality comes out to what they reveal to you so you can help them. And so I love that, coming to the exam room so you can have before you even go to the exam room, excuse me, you just, let's have a general conversation in a relaxing office. I'm sure your office is nice. You probably have nice little pictures around. So it's a calming effect. So people
I
are
try.
open to those kind of conversations.
Yeah.
So I'm sure that's what's going on there. Let's talk about technology, right? You kind of hinted at with AI. My company, we kind of focus on remote care as a service where we're kind of reaching out to patients in the home environment for remote patient monitoring, care management services. What are your thoughts about that, right? There have been stats that say, most people see the doctor like 1% of their lives, right? They spend the vast majority outside of the doctor, the clinic environment. So they're at home, they want to manage themselves. What are your thoughts about these advent of these tools and how they can be useful for you in the primary care setting as you think about, how you practice medicine?
I think it's amazing, honestly. Number one, it gives patients that sense of empowerment and that sense of involvement in their care. Before we had all of these fancy tools, we'd have blood glucose checking. They would prick themselves and they write it down in a notebook. And the patients that are very invested in their healthcare are the ones that bring in a notebook and they say, Doc, these are my blood sugar numbers. Morning, fasting, before I ate, when I got my insulin, and things like that. And not only just sugars, but even in blood pressure, hypertension, they come in and they're like, these are the numbers I'm seeing, Doc. This is my number in the morning. This is what it looks like after I take my pills. This is what my blood pressure looks like in the afternoon. And it's not only empowering for the patient, but it helps us as physicians so much, because you in the office, like seeing me in the office is just one point in time. It's just one data point. And I don't know if glucose per se, you can get like super, super high sugars because you're kind of nervous about seeing the doctor. I don't think there's anything that but we have white coat hypertension. We have, when they come in and their blood pressure is extremely elevated, and sometimes I'm sitting there and I'm like, this doesn't look right. You get an EKG on them. There's no evidence of high blood pressure, because you can see that if there's some sort of structural changes because of the high blood pressure, it will reflect on your EKG strip. And sometimes you look at it and say, blood pressure every time he's in the office is like 160s, 170s over 80s or 100. But the EKG is not telling me the same story. It doesn't look like it's a chronic problem. Because they can get nervous. Sometimes I get nervous and I go and see my doctor, even if I'm the doctor, I'm sitting there and like, oh my gosh, you still get the nerves. And just having all those data points helps you as a clinician, helps you and your patient make an informed decision. It's not about, okay, this blood pressure is 180 over 100 and last visit it was also 180. Let's go ahead and throw like a very strong antihypertensive. I've seen the mistake where we would do that, and then they would come back in saying, hey doc, I've been dizzy and nauseous and my blood pressure apparently dropped when I went to the pharmacy to go and check on it. It was like 90 over 6. I'm like, oh my gosh, because I over-controlled you, because that data point that I was making my decision on was not accurate. It does not show me what all the data points were going towards, right? Same thing when it comes to blood glucose checking or blood sugar checking. Sometimes you tell your patient, hey, I want you to get labs. We usually tell you guys, you need to be fasting. Don't eat for like 12 hours or so until you get your labs done. And then you have like a low sugar, or sometimes it's a normal sugar. But interestingly enough, I was looking into the literature one time. It's actually what we call the post-meal, the postprandial sugars that actually drop first. Or not drop first, but kind of go up first before you see it in the morning sugars, the fasting sugars. Just having that continuous monitoring of sugars, like, okay, what is the range? And then again, it's not just about having that one data point where my patient has a high blood sugar of 400. I'm going to go ahead and chase that one data point with a bunch of insulin, or maybe like scattered data points, and then I make my patient hypoglycemic, and that's even a bigger risk to them, right? Understanding that, wait, maybe the patient's blood sugar kind of ranges within, like, let's say if they're very, very, very diabetic, 200 to 300. That's their range that their body is used to, and we have to do this slowly. And just having these devices is just so helpful to make sure that we're making informed decisions and safe decisions for our patients.
No, you hit the nail on the head. I mean, it empowers the patient. We're seeing that. Also creates a deeper bond between the patient and the doctor, because now the doctor is getting data and can kind of be a little bit more connected to the patient. The patient feels like they're being seen more. We're seeing adjustments with patients, not just with blood pressure and glucose monitoring, but other things that can help with the patient, right? Like say they need additional help or care, or maybe there's emergencies that happen that the patient wasn't aware of, like maybe they had a mild stroke or something, but because we were reaching out remotely using telehealth means, we were able to kind of see that and get the patient 911 services, right, immediately. So just having that kind of connection is really important. And to your point, I think AI is great. I don't think, my belief is, as a technologist, I don't think it's ever going to replace doctors and clinicians, because yes, it can be very helpful in certain cases for diagnoses, but it does a thing where it tells lies sometimes, right? Because it's not giving you the best context. So having a doctor that's looking at the data, looking at what the AI is giving them, and then putting that into context is going to be way more important. One of the things I'm seeing a lot of my doctors start using, some low level technology tools like dictation services, right, to help with administration. And I can make it a little bit faster for them. Some billing tools, maybe to help with prior authorization, right? There's some technology tools and AI that's helping speed that process up. So making sure they understand what patients qualify for reimbursements prior to going through the normal processes of delivering services. So things like that are coming to the forefront, where we're seeing more and more doctors kind of play around with it, especially some of the younger ones, right, who are interested in this, but it's a lot of burden because I know the core, a lot of the doctors that we talk to is patient care, right? Making sure that top of mind, that they're doing what they need to do, make sure the patient gets better. So sometimes trying to crush the other stuff in there gets a little difficult. So
Agreed.
how are you communicating now to like the organizations you talk to about integrating artificial intelligence into their operations and things like that? What are some high level things that you recommend? So let's say that some of the multi-specialty groups or the accountable care organizations we talk to, what are some high level enterprise wide thoughts that to bring AI in that they need to think through?
Yeah, that's a great question. Actually, I was at an event yesterday afternoon with a group that looks at high level, basically the security of systems. And so basically looking through a healthcare organization or a baking organization or a manufacturing organization and basically looking at their entire scope of technology landscape within their organization and ensuring within their system that everything is, number one, working properly, but number two, ensuring that there's not an issue with any type of outside application, i.e. a threat type of application coming into the organization. So that's a big thing. And I think as we're moving forward, you mentioned HIPAA earlier, protecting the records, protecting information of the patients, protecting that data, that is kind of the highest level that you can have. And, I want to make sure that physicians that are listening to this, that's your probably key priority, is making sure that your systems are working correctly and obviously very secure. So that's number one. Number two is really from a application standpoint, it's the ability to ensure that good data side of things. If you are using high-end EHR system like an Epic, Sun, or Allscripts, et cetera, that information is being fed in properly, that information is obviously secure, and then obviously can run through your system, along with pulling in other vendors that have that secure type of data set. That is a big element. And then I think the last kind of point is just, again, as you mentioned, Theo, it is one of those things where you want to have that cautionary kind of viewpoint on the outbound information that's coming back to you to ensure that that data is good going in to give you that feed of information in a good way. You just want to make sure that you don't 110% trust the data. You might want to trust the data at 90 to 100%. And just again, if you have that kind of itching in the back of your neck, then do questioning.
You hit the nail on the head with that. So security, data integrity, and just outcome verification, right? And
Yep.
put those three into a system from an enterprise level, you can have a process that at least starts the beginning ways of understanding how you can implement artificial intelligence and other technologies into your enterprise. So that makes sense. Thank you for listening. If you like what we just talked about and you want to learn more, click either to the right or to the left, and you can find out more information about how we can help you this year.